Hi everyone, this is Image of the Week brought to you by me, Dennis, first year emergency medicine resident, Jackson Memorial Hospital, for the week of November 12th, 2018. Into it. Our case is a 65-year-old male patient brought in from a nursing home after being found down on the ground. When asked, he has no complaints, and he states he thinks he accidentally rolled out of bed, has had no prior history of falls or mobility issues. Vital signs were within normal limit, and on exam, he had no bruising, no obvious deformities, was actually able to reposition freely in bed and move all four extremities, though he was noted to be favoring his right leg in an externally rotated position. Therefore, this prompted me to grab the ultrasound and take a look, see if we could find any fractures or dislocations. So on the left here is my scan of the unaffected left hip, scanning in the transverse plane on the anterior aspect, starting at the hip and moving inferiorly. As you notice, there's a rounded hyperechoic line at the superficial aspect of this image, which represents the cortical line of the proximal femur, and you can see the shadowing artifact that obscures any of the posterior imaging. Now on the right, we have the affected right hip, and let's compare to what we saw on the left. So as you can see in the later portion of the image, I saw a disruption of that cortical line, and you can see shifting of the shadowing artifact, which increased my suspicion for there being a fracture in this patient despite his minimal complaints of pain. Next, we have longitudinal views of similar areas, starting on the, again, normal left hip from the lateral aspect. So you can get a sense of the anatomy. We're looking from the greater trochanterior medially, and we see this nice rounded, smooth cortical line throughout the image, scanning somewhat anterior and posterior fanning, just to get a better sense of the anatomy. And then on the right, we again see a very obvious disruption of this cortical line. We see continuation in an angular displaced orientation compared to the superior segment. And again, you see a change in the shadowing that kind of ends abruptly at the end of that superior segment. So here's the x-ray. And as you can see, there's confirmation of our suspicion from our ultrasound images of a comminuted fracture of the proximal femur involving the greater trochanter, which we saw in our transverse imaging here. And then as we came down on our lateral longitudinal imaging, we saw this large femoral shaft fracture. Note that on the ultrasound imaging of the longitudinal view of the femoral shaft, you could see the beginning of the overlap here, but the shadowing artifact obscured our ability to determine the actual degree of overlap with just that one single view. In the future, if you're planning on diagnosing and describing these orientations, orthogonal views with ultrasound would have given more information, as well as a transverse view of the same area. In this situation, X-ray had already been ordered and was planned, but in certain populations, if you're trying to avoid X-ray, additional ultrasound imaging could have provided more clinical information. And we'll take a look here again, just knowing the X-ray imaging in mind to look at the fractures here. Again, as stated, we don't see the degree of overlap because of the shadowing artifact of the superficial cortical border here. In resolution, the patient was admitted to orthopedics, received his open reduction and internal fixation the following day, and was having an uncomplicated recovery course at the time of my follow-up. Pearls to be taken away from this case: X-ray is not 100% sensitive for picking up femur fractures. About 10% can be missed, according to current literature. In this case, it was obvious, but it's good to keep in mind that clinical suspicion should still be pursued